whenever you start study. Okay, and before sitting in your AKT, before going in your OSCE hall, in your talks hall, in your theory exam, it will help you as a magic. Okay. All right. So let's start our topics. So in this session, what we will cover in a generalized body aches and pain syndrome, we have to discuss almost three main topics. Okay, one is chronic fatigue syndrome, and these all look similar. Okay, so that's why questions are very tricky in your exam. So there is chronic fatigue syndrome, there's polymyalgia rheumatica, and giant cell arthritis and fibromyalgia. So first of all, chronic fatigue syndrome. As the name shows, that someone is dealing with something, or you can say a fatigue which is chronic. Okay, so it's also called as myalgic encephalomyelitis. Okay, so it's a chronic fatigue syndrome. It runs as a chronic pattern. Okay, and it is a multi-system kind of problem, a quiet condition characterized by debilitating fatigue. Patient used to feel fatigue all the time. Okay, they don't want to do anything, and once they get themselves into some work, they get so much tired that they cannot get out of their bed for quite 1 or 2 days. Okay, their body hurts in that way, and it is most of the time post exertional malaise. Okay, we have seen so many patients of it. They comes to us that, and they says that I cleaned my house yesterday and now I am having whole pain in my body. I have no energy and I am feeling like my body is hurting all the time and I am feeling like tired all the time. So this is a post exertional malaise. Okay, and then there is a range of cognitive and autonomic symptoms as well. All right, so according to the NICE, chronic fatigue syndrome is a real thing. And what happens when such it is since it is more prevalent in female patients, and females are having a 3 to 2 ratio, like every um, like female patients are more. Okay, and the age is between 24 to 45 years of age. And when they come to our OPD, to our GP, and we are taking history, what we say to these patients? Oh baby, तुम्हें तो कोई मसला नहीं है, ठीक है, ये दर्द है तो आम दर्द है. This jumla is a lethal jumla. This sentence is lethal, dreadful sentence for the patient. Never use such sentence for your patient. Okay, because they are having some problem. That's why they are sitting here. Okay, so we as a GP, the first thing is that we have to acknowledge the suffering. Okay, if someone is having pain, okay, we understand that you are having pain. And then what GP do? They used to send them for so many tests, and all tests come, all lab investigation comes normal. And then again, we used to say that there's something supratentorial or there's something going in their mind and somewhat like that. No, this is actually a disease. NICE has classified it, and other guidelines also classified it as a whole big disease. Okay. So if we talk about the prevalence, it estimated in UK population, it is 250 lakh affected in UK, though these are those patients who are documented, and there are so many which is not documented and got false medications and or got false consultations. Okay, so its worldwide prevalence is 0.2 to 0.4%, up to 75% have moderate severe symptoms, which limits their daily activity. Okay, so demographically, females are more prone to it, and 25 to 45 years of age, they are mostly having, and rare under 10 years, but children can also have these kind of problems. Okay. So prognosis is variable. Someone get fully recovered, okay, and some will have many improve with pacings, and severity determines prognosis as well, how severe the symptoms are. Okay, and If it gets more severe, then it will lead to the patient to bed bound, even house bound. They cannot get out of their bed and they cannot move out of their house. All right, now talking about diagnostic criteria, NICE, according to NICE guideline, 2021 is the latest one. Okay, they are saying that if someone is having fatigue for such debilitating fatigue, which is more than 4 months in adult, okay, can be more than 3 months in children or younger people, but at least these symptoms must be persist in the patient for more than or equal to 4 months. Before that, you cannot label them as a CFS or chronic fatigue syndrome. Okay, that's important. New onset, and that should be not lifelong, and unexplained limit activities or unexplained kind of symptoms. Okay, they are having joint pains, they are having body aches, they are having malaise, they are having appetite disturbance, they can have IBS kind of things, they can have arthralgias. Okay, so mood swings, so they are having so many kind of things. Okay, and then there is a post-exertional malaise. When they do some heavy work or any heavy chore of their house, they start getting this problem. Okay, worsening of symptoms after physical or cognitive exertion. Onset is typical 12 to 48 hours after activity, and duration is more than 24 hours, and that can last 2 days to weeks. Okay. Then there can be one or more of following additional features. They have having their disturbed sleep, they're having their brain fog or dizziness they can have, or orthostatic intolerance that can also, that they when they stand up from sitting, they can have tachycardia, they can have palpitations, or without any hypotension they can feel dizzy. All right, so this is orthostatic problems. So all three criteria must be present for diagnosis, and there should be more than 4 months, have 4 months passed in the individual, then you can label them. All right. So there can be neurological autonomic symptoms. Patient can feel vertigo, dizziness, postural drops, or postural dizziness, once the orthostatic dizziness. Okay, they can feel numbness or paresthesias in their fingertips or in their toes. They can be very sensitive to light or sound. They can get anxious, like if there's someone shout in sitting along with them, and they said, "Don't shout in front of me." Or again, they get irritable at once. All right, and they are having, of course, headaches. They can have muscle twitching. Then psychological impact of this disease is also very important. They can have mood swings, irritability, panic and anxiety attacks. If it get prolonged, they can went into depression as well. Okay, so then they can have difficulty in concentration, whatever they are doing, or they cannot do very keen or very minute works. All right, and they can have IBS type of symptoms, food intolerance, palpitation, temperature dysregulation. Sometimes uh, they can feel hot, or sometimes they can feel cold. So this is a temperature dysregulation as well. So the lady will be telling you so many, you can say, variety of symptoms. All right. So these features are supportive, not diagnostic. Their presence helps severity classification and guides symptoms management. So then they classify it according to severity of the symptoms. There is no classification of CFS or chronic fatigue syndrome. It is just a classification of based on severity of symptoms. Okay, it's not a classification of chronic fatigue. It is a classification on the severity of the symptoms. Some will getting mild symptoms, some will be getting moderate, some will be getting severe and very severe. So this is how they classify. In mild, which is able to perform activities of daily living, but with reduced stamina. Okay, so they can manage themselves by only education and reassurance, which can be done in primary care. And someone get moderate symptoms like substantially reduced mobility with significant limitation in daily activities. Okay, they will come to you and they can say, और डॉक्टर साहब, कल हमने कपड़े धो लिए अपने घर में, आज तो उठा ही नहीं जा रहा बेड से, और अब ये ऐसा ही होता है मेरे साथ. ठीक है, so that's a moderate kind of. So activity very limited, requires frequent rest, not in work. All right. And then primary care mostly treat them. There is no need to send them to specialists until unless there is any constitutional symptoms or if there is any unlikely symptoms is happening. Severity are, of course, as the name shows, they are housebound or they become bedbound. Okay, then you can send them to specialty and there can be other supportive groups that can help them in their daily activity. Okay, and then very severe will become fully dependent. They cannot even pick a glass of water themselves. All right, so its exact cause is unknown and it is having a multifactorial uh, cause, or there is no exact etiology which is known, and there is no single causative agent as well. But the most of the time they says that guideline says that it is any after any infectious disease. Okay, maybe after any viral infections. Okay, so that can be the trigger point, or that can be the causative agent, because we have seen so many people after COVID went into CFS. All right, so this is the a very strong etiology so far, that it can happen to anyone after having a little bit prolonged course of viral infections. All right, then because of there is immune dysregulation, there is elevated pro-inflammatory cytokines which put them into such symptoms. Okay, so evidence of immune activation and T cell exhaustion is there. Immune activation and chronic inflammatory signaling implicated there. Okay, and then there is neuroendocrine dysfunction. Okay, there can be HPA excess, hypopituitary excess, hyporesponsiveness. They can start producing low cortisol in some studies. They says that, and especially when patients is having postural tachycardia syndrome, so they says that studies say that, or guidelines says that there will be neuroendocrine dysfunction as well. All right. And then someone also get some people or some patients can also, this is again in the guideline, then they can, after having a course of immunization, they can develop chronic fatigue syndrome as well. And then there is some predisposing factor, which is genetically susceptible, pre-existing anxiety or depression. People can get into CFS, or female patients can get into a CFS. Mitochondrial or metabolic etiology emerging evident. This is the new one. This is not in previous guideline, that mitochondrial and metabolic involvement is there. This says that there's emerging evidence of impaired cellular energy metabolism going on in the body as well. Okay, so that can be possibly linked to reduced ATP production under exertion, but still it is under still under consideration. No, that's why it's not in Oxford and other books. So you have to see the red flags. What are those? If there is any unexplained weight loss, then think of other disease. There are so many things that you have to rule out first before labeling anyone with CFS. Okay, so significant unexplained weight loss, if there is any significant unexplained weight loss, then think of any malignancy like lymphoma, any tumor of GI or lungs. There can be TB, there can be inflammatory bowel disease, any Addison's disease are also mimic like CFS. Okay, and if there is neurological symptoms, especially focal neurology, like only having paresthesias of fingers and toes, then think of any SOL or any MS or motor neuron disease. Okay, so only alone symptoms of paresthesias can happen in CFS patient, but you have to rule out other causes as well. All right, then there can be sleep. Patient sleep is very much disturbed. They can have bouts of hypersomnolence and high Epworth sleepiness scale score. Okay, then you have to refer them for sleep study. Okay, cardiorespiratory disease, exertional dyspnea, if patient is having all the exertional dyspnea, chest pain, hemoptysis, of course there can be cardiac respiratory workup will be applied to these patients. You have to send them for